In the next 5 minutes, I'm going to present to you the main findings of a first large cohort study on RFC1 disease, and I'm going to invite you to a novel multicenter longitudinal natural history study. Regarding the phenotype, I don't have the time to talk about basic features of ataxia and canvas, but I would like to report the prevalence of RFC1 disease in certain clinically defined syndromes. Among patients with canvas, the prevalence of RFC1 was 68% in our cohort. Interestingly, in patients with the syndrome of ataxia with chronic cough, the prevalence was 100%, suggesting that this syndrome is highly specific for RFC1 disease. Regarding other system involvement, we noted that autonomic dysfunction is indeed a prevalent feature of RFC1 disease, more than 60% of patients, but there is also bradykinesia in more than 30% of the patients, giving rise to the picture of MSA type C in about 20% of patients. Moreover, there was postural instability with retropulsion, there was slowing of vertical saccades that could mimic PSP type C, and there was even hyperkinetic movement disorders such as orofacial or limb dyskinesia and facial dystonia. Regarding disease progression, we analyzed the onset of gait ataxia, which was late onset with an average of 53 years. We analyzed other features of the disease relative to this onset of gait ataxia and also observed that chronic cough precedes the onset of gait ataxia in many patients, even by decades. We noted that falls and autonomic dysfunction are very early features that can even be present at the onset of gait ataxia. And we report that upper limb involvement, dysarthria or dysphagia are still relatively early features with occurrence of 5 to 10 years after the onset of ataxia. Functional disease progression is moderate, with 50% of patients depending on a walking aid after 10 years and 20% on a wheelchair after 15 years of ataxia duration. Progression of ataxia as assessed by the SARA score is also moderate, with an average progression rate of 1.3 SARA points per year. However, with a marked inter- and individual variability, if we look at the longitudinal data, there are patients with comparable ataxia severity with a latency difference since onset of more than 10 years. And there are phases of rapid acceleration up to 5.5 SARA points per year. Based on this, we have calculated preliminary sample size calculations to show that these clinical outcome measures are limited if we think of trials. We would still need more than 130 patients per trial arm to show a 50% reduction of SARA progression. Given these limitations, we have started a multimodal natural history study of RFC1 disease with a protocol which is currently under development. And this protocol so far comprises the clinical assessment of motor function, cognition, speech, or dysphagia. It includes the sampling of fluid biomarkers, digital motor assessments with sensors such as APDM, digital vestibular assessments, and brain MRI. We are fortunate to start with experts from around the globe who will push the natural history study. We built on resources that are already available, such as the patient registry, the ARCA registry with over 30 recruiting sites worldwide, established data protection policies, well-known front end. We built on harmonized biobanking and test protocols from other, for example, European Joint Program projects such as PROSPECS. However, it is important to mention that this is still under development, and I would like to invite others on the ARCA Global Conference with different ideas I've seen as suggestions like genetic modifier investigations, patient-reported outcome measures, to join this natural history study to make it a really global effort to push RFC1 disease towards trial readiness as soon as possible. With this snapshot, I would like to Thank you for your attention, and I'm looking forward to questions and discussions in one of the break sessions.